So let's talk a little about hypertension. So just in general, why do we care about high blood pressure, whether the blood pressure is high or not? And then over what time course do we care about it? So is this a problem where we worry about blood pressure going up for one day, one reading, or is this something we care about more over a chronic year period?
So I think you have two different scenarios. I think that as a public health issue, hypertension is very predominant in the country. And if you go by the last guidelines, you should be getting a treatment if your systolic number is more than 140 and your diastolic number is more than 90, you should be doing something about it. And now, what is that something about it ranges. So if you're overweight, it is clearly demonstrated that by losing weight, you may lower your blood pressure. So if you're overweight, taking care of the weight will be a first strategy. If you eat a lot of sodium in your diet, decreasing the sodium intake will be important. And if you restrict, the use of canned foods, canned soups, not adding salt to your meals. There are things that you don't have to add salt to. If you go to a Mexican restaurant and you get the whole chips, it's going to be a lot of salt. You don't have to put more salt on it. So avoiding salty meals will be good initial steps. And it could be that if you are in the borderline, you're having top reads of 150, 155, with these lifestyle modifications, as I said, losing weight, paying attention to the salt, and performing aerobic exercise, and the recommendation is 30 to 45 minutes, 3 to 4 times a week of a straight aerobic exercise, non-stop, biking, swimming, treadmill, whatever you want to do. But walking at workplace and sitting doesn't count. It has to be a dedicated 30 to 45 minutes, 3 to 4 times a week.
Sitting at Burger King doesn't
that doesn't do it. So you could bring that blood pressure lower. Now, it is unlikely that if you presented with a blood pressure more than 160, that these lifestyle modifications are going to do it. Now, you have to see it in a context. If you are having pain for whatever reason, let's say you have a hip problem and you're having pain, then the adrenaline rush related to the pain may be raising your blood pressure. But if you're doing fine and you're not having symptoms, and yes, you went to the doctor's office for a checkup and your systolic blood pressure is more than 160, chances are that you're going to need an agent to bring that blood pressure. Even though that's the case, in most of my patients, I will start with lifestyle modifications and will check in 2 or 4 weeks and see how they are doing. I may recommend to check the blood pressure in the outpatient setting, and then if it's more than 160, then we decide which agents are we going to take. The last JNC recommendations say that if you're older than 60, then you can move that. It doesn't have to be 140, it could be 150, your trigger for your goal. And there's a lot of doctors that are not following that, and there's a lot of controversial because this decision was just made in an expert opinion rather than in any data. So, but as we stand now, if you're older than 60, you don't need to be treated unless your blood pressure top number is more than 150. For anybody else, then your blood pressure should be less than 140. Unless you have renal failure or you have diabetes, in which case, even if you're older than 60, then you need to be 140 over 90. So why is it important? Because you're not going to feel symptoms most of the time for your high blood pressure. And your vessels in your heart, in your brain, in your kidneys are seeing that high blood pressure and are reacting to it. So they may develop plaques inside that will lead to blockages. If it happens in the heart, that leads to a heart attack. If it happens in the brain, that leads to a stroke. And if it happens to the kidneys, that leads to renal failure. So it's the silent killer because you don't feel anything. For you to have symptoms related to high blood pressure, it needs to be a very high blood pressure. So if you don't have any underlying coronary artery disease or brain disease, for you to have a headache with high blood pressure, chances are that you need a 190 or a 200 systolic blood pressure to have it. So if you're waiting for symptoms to treat your blood pressure, you're probably waiting too long. Now, this elevated blood pressure could cause atherosclerosis, which is the blockages that we're talking about, but it could also lead to thickening in the heart muscle. The heart muscle is a muscle, and now like your biceps gets thicker when you are lifting weight, the heart muscle becomes thicker when they're facing a high blood pressure, and then that may not affect the contractile property of the heart, but it may affect the relaxing property of the heart, and that is what leads into diastolic heart failure. So we need to treat it because it's a risk factor for atherosclerosis, therefore for heart attacks and strokes, and also renal failure, and it also leads to congestive heart failure because of thickening of the heart muscle.
Very good. So a couple of things I heard there is that blood pressure, high blood pressure, is bad over a long period of time, but not necessarily over short periods of time. And that there are some conditions, painful conditions, for example, or stressful conditions that can temporarily increase your blood pressure. The environment that we practice, we typically see people in those stressful conditions. Even though we do have some people who call us just to see us, most people call us when they're under a fair amount of stress. So isolated blood pressure, not so dangerous. It's the blood pressure for a long period of time. One thing that we see a lot in the emergency department is the headache with high blood pressure. And people assume that if they have a headache, it must be because their blood pressure is high. And the interesting thing about it is that it's the classic reason that distinguishing between causation and correlation is important. Blood pressure and headache can be related, but it turns out that headaches can cause your blood pressure to go up.
And that's absolutely
not
correct.
the other way around. So those are the reasons that we want to treat blood pressure. We don't necessarily, you had mentioned if you are asymptomatic, so no symptoms whatsoever, and you just happen to notice a really high blood pressure, there's no real magic number. You don't necessarily want to lower it rapidly.
You probably don't want to lower it rapidly.
Why is that?
Because if your blood pressure has been elevated for a while, your small vessels in the brain and in the heart have adapted to fight that high blood pressure. So they have constricted in order to protect the vasculature that is distal to them. So they are depending in that high blood pressure to keep some perfusion. If you drop it suddenly, now the blood pressure will be too low in the system to be transmitted until these vessels relax again. And you may end up with, organ hypoperfusion. There is a process called autoregulation that has led into adaptation in the microcirculature to the high blood pressure. That's why I said in most of my patients I would wait I start with lifestyle modifications. And even if I know that somebody is going to need, let's say, 100 milligrams of metoprolol to control the blood pressure, I may start them at 25 and just wait a couple of weeks and see them again and then increase it to 50. And I let them know that it's not like we're failing in the therapy, but rather that we're titrating the therapy, because you want to give time for that autoregulation to occur. The exception to the rule is if you're having an acute organ damage related to that. And the exception is relative, because it's very clear in the heart that you want to drop that blood pressure if you can, if you're having a heart attack, or if you're having an episode of acute congestive heart failure. In the case of the brain, it may be a little bit more tricky, and you will see the neurologists pushing for maintaining the blood pressure elevated in the case of an ischemic stroke. In the case of a hemorrhagic stroke, they may be fine with us bringing the blood pressure low. I would say that in the case of cardiology, if you are having a heart attack and you are hypertensive and you arrive to the hospital in that setting, we can take care of your problem much easier than if you are now hypotensive in the setting of a heart attack. So even though the blood pressure should be controlled and nitrates should be initiated to try to bring that systolic below 140, you don't want them to be hypotensive. If you have a systolic blood pressure of greater than 190, let's say, or 200, then you want to bring that systolic in the 140s. You don't want to bring them to 100 or 90s if you don't have to. If you're bringing the patient here, you probably don't have to, because we'll take over after that.
Well, it's interesting. We used to, when I was first working as a paramedic in this system, we used procardia. We'd poke a little hole in it, squirt it into the tongue, because we were afraid that hypertension was going to cause a stroke. We stopped using that. And the reason we stopped using it wasn't because it didn't work, but because it did work. And ironically, the condition we were trying to prevent, stroke, we were actually making it more likely that we would cause a stroke.
Yep.
So it's interesting how medicine
The procardia
changes.
will work very rapidly, and there is no chance for the brain auto-regulation to reestablish, and then it will lead to hyperperfusion.